Welcome. I'm Dr. Patrice Harris. I'm a pediatric psychiatrist here in Atlanta. I completed my residency and fellowship training in child and adolescent and forensic psychiatry at the Emory University School of Medicine. I just completed my term as the 174th president of the American Medical Association, and I'm the first African American woman to hold that office. I am certainly honored to moderate this panel today as part of the partnership between GPB and Resilient Georgia. And this is part of the Mental Fitness for Resilience campaign. Today's panel will focus on health equity, racism, and resiliency. And I am so honored to be joined by three distinguished panelists. Dr. Terry McFadden is a general pediatrician and professor in the Department of Pediatrics at the Emory University School of Medicine. She is also Director of Primary Care Initiatives with Partners for Equity in Child and Adolescent Health. She is currently the president of the Georgia chapter of the American Academy of Pediatrics. Her academic and professional interests include health equity, comprehensive care for the underserved, childhood injury prevention, brain development, and medical education. Dr. Jean Brody is Regents Professor and Director of the Center for Family Research at the University of Georgia. The Center for Family Research has been named a Center of Excellence by the National Institute on Drug Abuse, and in the last 2 years, was given the Advances in Culture and Diversity in Prevention Science Award by the Society for Prevention Research and the President's Award of Distinction for Innovative Team Science from the Georgia Clinical and Translational Science Alliance. And last, but certainly not least, is Dr. Stan Sanu. Dr. Sanu is an assistant professor of internal medicine and pediatrics at the Emory University School of Medicine. Again, hope you noticed the Emory theme today. And he also serves as an associate program director for the Emory Internal Medicine Residency Program. Dr. Sanu obtained his medical degree at the Medical College of Georgia, completed his residency in combined internal medicine and pediatrics at Rush University Medical Center in Chicago, and did a fellowship at the Cook County Preventive Medicine and Public Health Program, during which he also obtained his MPH degree at Northwestern. His research interests include addressing and preventing adverse childhood experiences and integration of trauma-informed care in clinical practice. And I forgot to mention that Dr. Jean Brody also has an appointment at the Emory University Rollins School of Public Health. So Dr. McFadden, let me start with you. Talk a little bit about racism and how racism can be or is not, I'll wait to hear your opinion, an adverse childhood experience, or ACE. We hear a lot of talk about that, and how that relates to toxic stress.
Thank you, Dr. Harris, and fellow panelists. It's a pleasure to be here this morning. So we know that racism is a core determinant of health and leads to lots of social inequities, but independent of the social inequities, racism can be an adverse childhood experience. And, as my fellow panelists know, there's been a lot of talk about ACEs, or adverse childhood experiences, as the science of adversity has developed. And just to give a capsule view of adverse childhood experiences, the science tells us that traumatic events that children experience early in life not only affect their psyche or their psychology while they're young, but it really can predict long-term physical and mental health consequences for those children as they progress into adulthood. So it's not just a pediatric issue, it's an issue around the whole life trajectory. And so the way that we believe that these adverse childhood experiences manifest is because of toxic stress. Now, there's a lot of word soup about trauma and stress, and it's hard sometimes to separate out all the things that we're talking about. But stress in and of itself is not necessarily a bad thing. The Center for the Developing Child has come up with a framework around stress, where they talk about positive stress, tolerable stress, and toxic stress. So positive stress is when a child falls and a loving adult picks them up, dusts them off, and they find out that, yes, they can cope, they can deal with it. Tolerable stress may be a little less normative. These are not normal experiences. It may be significant, like the death of a parent or a natural disaster, but again, with a loving adult, a safe, stable, nurturing environment, that child recovers, develops resilience and coping mechanisms, and so it can be valuable to them. They learn that they can get through a bad situation. But with toxic stress, the exposure, the trauma is unrelenting and severe. And couple that with there not being a loving adult, a safe, stable, nurturing environment to mitigate that stress. That child experiences an elevation of their fight or flight hormones, which can affect brain development, particularly in the parts of the brain that have to do with executive function, which is a way that we learn. But it also affects immune response and the immune system. And even more, I think, concerning is the genetics, what we describe as epigenetics, the way that genes unfold. So this can not only affect the child in their early childhood and their brain development, but their lifelong trajectory of health, as well as it can be intergenerational, not just from the social inequities, but from actual changes to the genome. So this is a significant issue for children, and racism clearly is one of those ACEs, even though it wasn't included in that seminal study that looked at 10 exposures that children can have. If you look at more of a community experience, we know that racism is clearly one of those community experiences that can impact a child's brain development and long-term health.
Great, thank you. And Dr. Brody, pick up on that a little bit and talk about racism and how it can affect, again, lifelong health, particularly around chronic diseases.
Sure. It's great to be here this morning. And Dr. Harris, thank you for all you've done to promote the health and well-being of all Americans.
Thank you.
Our work focuses on children and families in the southeastern United States, those states that begin with North Carolina, South Carolina, Georgia, Mississippi, and Alabama. And if we look closely at the epidemiology of what it's like to raise a child and grow up in those places, it can be very challenging, particularly if you're a Black person. The poverty rates are among the highest in the nation for Black children and families. And over half, or nearly 60%, of Black children in these places grow up in poverty. And what's remarkable is that despite this epidemiology, so many Black children grow up to be competent, healthy, and have good mental health. If we look, though, at the epidemiology or the prevalence of chronic disease at midlife, we find that children who grow up in these places are 30% more likely to have chronic diseases. And by chronic diseases, I mean heart disease, diabetes, hypertension, stroke, and even dementia. And the prevailing view has been that these diseases appear at midlife. And actually, we take a different point of view on that. We look at and believe that the origins of these chronic diseases begin in childhood, early childhood, and maybe even before birth. An important contributor to the development of chronic disease is we believe that across childhood, children are exposed to racist encounters, and those racist encounters can change their biology in a way that makes it more likely that they'll develop a chronic disease when they do reach midlife. And this is important from a prevention point of view, because if we can intervene during childhood and develop shields from racist encounters, we can promote the health of children and their children. So we set about to figure out if encounters during adolescence somehow changes children's biology, adolescents' biology, so that they become more likely to develop a chronic disease at midlife. And this was no easy feat, and we started about 10 years ago. And what we did is we tracked exposure to racist events in several hundred Black high school students. And we followed them for 3 or 4 years. And then after they left high school, we collected a bundle of markers of their health, including their stress hormones, cortisol, epinephrine, or norepinephrine. We looked at the levels of circulating inflammation in their bodies. We looked at their blood pressure. We looked at their adiposity, and wanted to see if exposure to racist encounters would be associated with this bundle of health markers that together predict or would predict the chronic diseases of aging later on in life. And what we found was indeed more exposure to racist encounters, which could be slurs or physical harm, false accusations from police or business owners, or having a guidance counselor telling you that you're not smart enough to take a certain course or to go to a certain college. All of those things over time together predicted those markers that would indicate at midlife that these young people would indeed experience chronic disease. An important thing we found, though, was that there was a sizable minority of youth who were exposed to these racist encounters and yet did not show elevation in these health markers that would forecast poor health later on. And this is a very important group to understand.
You know, that is critical. I get that question a lot about resiliency, particularly now with COVID-19, and people ask if I predict a mental health crisis. And certainly it's no way to know if there will be a crisis, however we define that crisis. So it's not inevitable, though, but we need to look at what we need to do right now. And one more point, and then this leads to Dr. Sanu, is I'm so glad that you talked about poverty. And certainly that's one of those social determinants of health that, again, has been driven by larger structural determinants of health, such as racism and bias and all of those things. But you also separated out racism as its own independent variables, because I think we know just across the spectrum, we certainly don't have time to go into it today, but no matter your economic security, you can still be affected and impacted by racism. And I think that's one of the reasons we are thinking that even African-American women who have insurance and have some economic security still are impacted by the statistics around maternal mortality. So I'm so glad that you're looking at these as independent variables, because far too often people think that there has to be an intersection there. And so, Dr. Sanu, you've done a lot of work, again, speaking of racism and biases and how these show up in healthcare. So say a little bit more about what you can teach us about these biases in healthcare.
Well, thank you so much, Dr. Harris. It's an honor to be here and to be a part of this panel. Thank you for that question. I think what I'll start with is to just make the point that where this all started. First, we know that there are a multitude of health outcomes that differ in prevalence and severity by race or ethnicity or along other socio-demographic lines. And so we know that there are differences in these outcomes when it comes to different types of cancer, whether it's colorectal cancer, lung cancer, breast, ovarian cancer, whether we're talking about heart disease or infant maternal mortality, or even surgical outcomes, so vaginal birth after C-section, and the likelihood of success in some of those sort of clinical scenarios. And so that's not debated. I think the real question is when we step back and we observe these differences in health outcomes by race specifically, the question is why? And what Dr. Brody shared and what you just shared, Dr. Harris, what we know is that this is a complex, historical, multifaceted problem that spans multiple social ecological levels. So it's a complex problem as to what has caused and led to these and promoted these health disparities that we have seen for a long time and continue to see today. Racial bias in healthcare, I think, is certainly an important contributor to this disparity. Although right now we don't exactly know to what extent. When we talk about racial biases, in general, there are two ways that we think about it, and especially how they present healthcare. So biases can be explicit or implicit or subconscious. So explicit biases, and I'm not going to spend too much time talking about this today, but these are the types of biases that directly or intentionally take into account observations made based on an individual's race. And so in recent weeks, there's been a lot of discussion around whether we should really be using race in some of these risk calculators or clinical algorithms. And the reason for it being called into question is if we don't know why the disparity exists, and then we go ahead and we do logistic regression and we put race as a predictive variable in a clinical algorithm, then we run the risk of perpetuating those disparities because it's not a genetic difference. It's not, race is a social construct. It's not a biological, there's no biological basis for race in this country. So that's explicit bias. The other type of bias, which I'd like to press a little bit more into, is implicit or subconscious bias. And so these are the attitudes or stereotypes about an individual or a group of people that occur on this unconscious, involuntary level. And the two important things to remember about implicit bias is that, one, we all have it. It's not a matter of do you have it or do you not have it. It's we all have it. And so it's not this, and the second point about it is it's not this intentional belief or idea. And so the goal isn't, when we talk about implicit bias, the goal is not to demonize anyone or isolate anybody, but nonetheless, we have to commit to acknowledging them and addressing them if we are committing to the longitudinal work of anti-racism, specifically as it pertains to this discussion. And so with implicit bias, there have been studies that have shown that it can influence clinical decision-making. It can bias people, again, on that subconscious or involuntary level to make snap judgments that lead to decisions that might disproportionately or differentially impact certain groups of people, specifically Black Americans. And so the thing about implicit bias studies is that implicit bias itself is a difficult construct to study. And for good reason, right? It's difficult to measure because it's actually something that if we do anything voluntary with implicit bias, we voluntarily suppress it. And so and then the way that we can measure it, at least in a study design, is it tends to be through the main mechanism tends to be through the implicit association test, or the IAT. And so that is just one way of measuring implicit bias. It's not going to capture the entire spectrum of it. And so despite the studies showing some conflicting associations between implicit bias and health outcomes, one thing we do know conclusively is that a pro-white bias, a pro-male bias, a pro-straight bias exists in healthcare among health professionals. That's been well established. And so the question then becomes, what do we do about it? And as I was listening to Dr. Brody share about the idea, the fact that racism is trauma. Racism is a pro-inflammatory, it can add to that pro-inflammatory state, it can add to that allostatic load. I think what I'd like to call attention to is understanding that this bias, racial bias, whether it's explicit or implicit, is trauma itself. And so if we can agree that trauma and racism encountered outside the hospital, in the community, in society, is a traumatic experience that can add to allostatic load, then why should racial bias encountered in the hospital, in the health system, be considered any differently? I think when we think about racism from a trauma perspective, there are some interesting associations that we need to recognize. The first one is that among people who have experienced substantial trauma, there is an association with this sort of inconsistent or erratic use of healthcare. For example, we know that people who've experienced substantial trauma have an increased likelihood of scheduling more primary care appointments, but then no show to them or cancel them at the last minute. There's also an association between trauma and utilization of the emergency department instead of having a regular primary care provider. There's an association with higher out-of-pocket medical costs. And then racism itself has been shown to be associated with delayed prenatal care. And so I think the important part about bias that we have to realize is that it's not just a driver of health disparities and some of these health outcomes that we pay attention to, but it actually can affect the way people who need health services engage in the health system. And if they engage in a manner that is not exactly aligned with what the health system would like them to do, or the way the health system is set up for that kind of patient engagement, it can lead to and promote difficult patient encounters, fractured relationships, miscommunication, misunderstanding, which can obviously influence clinical decision-making down the road.
You know, Dr. Sanu, that is such an important point. I remember training, of course, here at Emory, and we used to have a 75% no-show rate. And we used to just say, oh, we expect a 75% no-show rate. And until we began to have conversations about why do we have a 75% no-show rate. Now, we don't have the data that all of you have mentioned. We didn't have it back then that we have now, but that gets to some of the solutions. And certainly we won't be able to get into all of those today, but very important points you make. We just have a few minutes left. We are going to get around to everyone, but I would want everyone to recognize that we just have a few minutes left. But I do want to ask Dr. McFadden, certainly right now with COVID-19 and with the chronic and acute instances we see of racism, and of course some of these acute instances are police brutality. Talk briefly in this very complex topic and very complex times about the intersection of COVID-19 and racism and its impact on children and families in this moment.
Sure, thank you. So just trying to bring together what both Drs. Brody and Sanu have talked about. We know that race is a social construct and not a condition, but the disparities that go along with race and racism are real. And so what we see in this time of COVID-19 is that the most disenfranchised communities, African-American communities, Latinx communities, indigenous communities are at highest risk to contract COVID and to die from COVID. When you look at some of the data from states across the nation, but particularly in the Southeast, where you see, for instance, I think even in Illinois, 30% in Georgia, 30% of the population is African American, but some 70% of the deaths have been African Americans. And so this is a culmination of some of the disenfranchisement in communities. African Americans are more likely to be in those frontline essential jobs where there's limited PTO time. For children who we believe are less impacted by COVID, many of them are being cared for by elderly caregivers, grandparents, relatives who are high risk for COVID. So we see this convergence really of these generations really of health disparities that put African Americans and communities of color at highest risk to be affected by COVID. And so it's not surprising that we're seeing the sort of disparities that we're seeing at this point.
And Dr. Brody, you mentioned the key, and that's resilience. Why don't some of the youth in your study, or why didn't some of the youth in your study have the same level or reports of adverse health outcomes? So I know we could talk about that for hours, and that is, one key issue as we think about interventions or services. But can you briefly tell us what we know now about resiliency?
Sure. About 20 years ago, we wanted to find out, why was it that Black children exposed to racist events over a long period of time didn't have mental health consequences, such as increased depressive symptoms, anger, hostility, cynicism, and even aggression. And what we found, and what informed my answer here, is that those children told us that they had parents who, in our language, were emotionally supportive. The parents were approachable. They took their children's emotional temperature. The children would tell them about racist experiences. The parents helped them deal with this and process that experience, and gave them ideas and plans for how to deal with racist events in their schools and their larger communities. In the study I talked about earlier, we found the same thing, even though the study was done 15 years later. Those young high school people who were exposed to more racist events, but who did not show any elevations in their biological markers that would forecast chronic disease, also told us that they had parents who they could talk to about this, to help them process that experience with them. They felt like they were in a partnership with their parents. They had an arena of comfort that protected them or acted as a shield from keeping those experiences from getting under their skin.
Very good. And I think a new frontier in our research is sort of looking at how systems can help with this, because, we talk about that weathering effects, those cumulative, yes, not the acute, racist events that everyone can see, but those tiny, everyday microaggressions. So that is certainly an area for future reference. So last question.
Yes. If I can make one comment about what Dr. Brody just said. We know that safe, stable, nurturing environments, whether that's a parent or another caring adult, is critical to mitigating adversity, whether it's racism or the other types of adversity that our children face. So that's a crucial piece of what our society, what our healthcare system can do to help with trauma for our young people from racism or other forms of trauma.
And speaking of trauma, Dr. Sanu, talk a little bit about trauma-informed care. I just believe that we really need to increase our investment in trauma-informed care. But if you could briefly let us know what trauma-informed care is, and how can we bring a trauma-informed perspective really inside of healthcare, but also in schools and other institutions.
Oh, yes, absolutely. I think kind of going off what Dr. Brody just shared about what a powerful component of resilience includes, which is that centrality of relationships. And as Dr. McFadden just shared, that every child needs those sort of safe, stable, nurturing relationships to thrive and to be resilient in the face of adversity. Trauma-informed care is actually a framework that that is centered around that very idea of the healing power of a healthy and nurturing relationship. And so I think of trauma-informed care as not a checklist of things to do, but more of a framework, a lens by which we can be anchored to an empathetic or understanding or patient perspective. And so, Dr. McFadden and I talk about this all the time, but that key paradigm shift of what is trauma-informed care. So it starts with we understand what trauma is, we understand what kind of health outcomes they're associated with, and there's a multitude of health outcomes. And then we ask the question, well, if trauma is universal, but at the same time it's disproportionately prevalent among vulnerable communities, historically marginalized and neglected populations, then what should my guardrails be when I interact with not just my patients, but my colleagues, my staff, my family, my friends, right? And so the pivotal question, the paradigm shifting question is, it's not what's wrong with you. When you see behavior in another person that people would describe as problematic or counterproductive or counterintuitive or self-destructive, that we stop the knee-jerk impulse to say what's wrong with you, but we pause, we remember the association between trauma and health and these negative health outcomes, and we ask instead, really what's happened. And I think that mental pivot helps us to get away from, or making sure that we're not just looking at people as a set of diseases or problem lists, or they're defined by their medication, but really remembering that they're a person. It's sort of a way for me that I honor the humanity of every patient and family member that I work with. And so it's not an end all be all, but I think it's a starting place. And as it pertains to the conversation around bias, I think it's one safeguard that we have to be, called that we're trained in, because right now this kind of training does not exist systematically in our health professional educational programs. And so the idea that people in healthcare, health professionals can make it all the way through their training and not understand and learn about this link between trauma and health and the ways that it shows up in so many different chronic diseases and disease and disability and early death, to me is a problem that we have to actively partner together to address.
I really like the way you put that, and perhaps I am big on saying words matter. So I wonder, which will be a conversation for another day, but I wonder if we should not talk about trauma-informed care, because then people get into care, but rather a trauma-informed framework for all services, institutions, and care that we give. So certainly that's a great conversation that we should have going forward. Well, again, let me thank my panelists. I could have talked to you all day today. These are such important topics, and they couldn't be more important for a point of discussion at this time. We heard today about the importance of appreciating and understanding adverse childhood experiences in general, as we know them already, but also we need to include racism as a trauma for children and adults. We also learned about the importance of having a trauma-informed framework, really, for all of the services and institutions that touch people, again, certainly in healthcare, but also in our educational systems and in our justice systems. And we learned about resiliency. We certainly know that racism does impact health outcomes, both in the short term and the long term, but we also learned today that resiliency and learning about resiliency and children having a safe, stable, nurturing environment can add and support resilience in children and in adults. So thank you very much for joining us today. I hope you've had the opportunity to learn something new. I did. But more importantly, I hope today's discussion is a call to action for all of us, not only to learn more, but to do more. So if you'd like further information, you can see resources on the screen. Certainly, you can visit the website of Resilient Georgia. You can learn more about the Center for Family Research's prevention program at their website. And if you or anyone in your family needs access to mental health services, you can call the Georgia Crisis and Access Line, that's GCAL, at 1-800-715-4225. You can get immediate access to routine or crisis services, or you can use the app MyGCal to text or chat. Thank you.